everyone, welcome back to Static Cardiology here on EMTV. I'll be giving you an ECG rhythm and a scenario. On the bottom of the screen you'll see a timer for 1 minute and 30 seconds. This time closely resembles the average amount of time you'll want to be spending on each card during an actual National Registry exam. When the time is up, we'll go over the rhythm and I'll give you my treatment. Enjoy the card and good luck.
3, 2, 1.
There's nothing like a generic dispatch. Let's go ahead and take a look at the rhythm in a little bit closer detail to see if we can determine what it is. The first thing I like to do with any rhythm is determine the rate. Now remember, on a 12-lead ECG you're actually looking at a 10-second strip. So in order to divide this into a 6-second strip and then simply multiply the counted beats by 10, what I'll do is I'll take two of these lead groupings, which each represent 2.5 seconds, and then I'll add 5 large boxes to get my 6-second strip. Now I'll count my QRS complexes and determine my rate. I'm counting 9 QRS complexes within that 6-second strip, which will make my rate 90 BPM. The next thing I'll do is look for the presence of P waves. I'm seeing P waves present for every QRS here, so I'll measure this PR interval. The PR interval here appears within normal limits, and just by doing a quick glance of the QRS complexes and PR intervals on the rest of the strip, I'm noticing that the interval remains constant. This is important when you're ruling out something like an AV block. I'll then measure my QRS interval. The QRS complexes here are narrow, meaning that this rhythm is less likely to be originating in the ventricle and it's unlikely for a bundle branch block to be present. The next thing I'll do is compare the R to R intervals. I'm doing this because I'm looking for regularity of the rhythm. The R to R intervals appear regular. Because of all of these different factors, the narrow QRS complex, the fixed PR interval, and the consistent R to R, my diagnosis is going to be normal sinus rhythm. Now, let's go ahead and take a look at the rest of the lead groupings to see if we can find anything else more significant going on. The first set of contiguous leads that I prefer to look at are the anterior leads. I look at these first because these leads are correlated to the left anterior descending coronary artery, a branch of the left coronary artery that feeds the left ventricle. Lay people refer to an occlusion in this vessel as the widowmaker. In this lead grouping, I'm seeing significant ST segment elevation in multiple leads. V2, which can also be categorized as a septal lead, V3, and some in V4. I would have already met enough criteria to declare that this person is likely having an anterior MI, which is a significant medical event. Let's go ahead and take a look at the other leads. The next group of leads that I look at are the inferior leads, leads 2, 3, and AVF. I'm not seeing any elevation in leads 2, 3, and AVF. I am, however, seeing significant ST depression, particularly in leads 3 and AVF. There is some depression present, however, in lead 2 as well. ST depression on an EKG usually means there's some level of ischemia to the myocardium, especially in the context of an MI. It should be noted, however, that ST depression can also be found due to electrolyte abnormality or medication effects, but in the context of this scenario, this is a concerning finding. The final group of contiguous leads is the lateral. In my lateral leads 1, AVL, V5, and V6, I'm seeing ST segment elevation present in lead 1 and lead AVL. V5 and V6 are fairly benign. There's even some reciprocal change present when you compare AVL to lead 3. If you'll notice, AVL and lead 3 show a comparable amount of ST segment depression in lead 3 for the elevation present in AVL. This is another good indicator that this is a true cardiac emergency that's occurring because of the significant ST segment elevation present in the anterior leads as well as the laterals. My updated diagnosis of this rhythm is a normal sinus rhythm with anterolateral ST segment elevation. Now, let's go ahead and take a look at the scenario.
EMTV.
You were dispatched to an office building for a 47-year-old female with a complaint of general illness. Upon arrival, your patient reports that she has been feeling nauseated and sick to her stomach for the last 24 hours. She reports that her coworkers called 911 because they were concerned that she appeared pale. She denies any medical history, but reports that she is a smoker. She is alert and oriented, lung sounds are clear to auscultation, and she denies any shortness of breath or dizziness. Your partner obtains the following vital signs: blood pressure 149/96, pulse 89, respirations 19, SpO2 96% on room air, and a blood sugar of 98. You attach the monitor and obtain the ECG above. In order to be successful in static cardiology, not only must you identify the rhythm correctly, but you must determine whether or not it is stable or unstable, and then apply the appropriate treatment algorithm. For unstable criteria, I use the acronym CHAD. And this, of course, stands for cardiac insufficiency, hypotension, alteration in mental status, and dyspnea. Based on my patient's presentation as well as her vital signs, my final diagnosis for static cardiology is going to be a stable sinus rhythm with an anterolateral MI. Now, let's go ahead and move on to the treatment. Just like with all my other cards, I'll begin treatment by regurgitating the mantra, Scene Safe, BSI, IV O2 monitor. Now, although my patient doesn't explicitly complain of chest pain, she may be experiencing what's known as atypical chest pain symptoms. So a trial of nitroglycerin may not be a bad idea. Dosing for nitroglycerin is 0.4 milligrams. Give it sublingually, either as a tablet or spray. Repeated every 5 minutes to a maximum of 3 doses. As part of this ACS pathway, aspirin should also be administered. Dosing for aspirin is 162 to 324 milligrams given PO. For the nausea, we could consider administering Zofran, 4 milligrams IV, and for any other discomfort that may arise, morphine, 2 to 4 milligrams IV push, or fentanyl, 25 to 50 micrograms IV, should be sufficient. Due to the severity of this patient's condition, it would be a good idea to put defibrillator pads on the chest. And this is because MIs that involve the left coronary artery, particularly the LAD, as they progress, will often begin to develop lethal ventricular dysrhythmias, such as ventricular tachycardia or VFib, so it's always good to be ready. And finally, rapid transport, particularly to a destination hospital with PCI or percutaneous intervention capabilities, otherwise known as a cath lab. And that's it. If you enjoyed this card, please make sure to head over to my channel for more. And while you're there, make sure you like and subscribe and check out my other playlists. I also have a shop on Teespring, so make sure you pick up some merchandise to help support my channel. I appreciate the support that each and every one of you continues to show my channel. It's such a proud achievement for me to be able to publish my 50th card, and I couldn't have done it without you. Until I see you next time, stay safe, keep washing your hands, and have a good rest of your night.